4 years ago, I sliced my hand open on a mandolin making dinner. Nothing dramatic. A little blood, a lot of swearing. 90 minutes in an emergency room watching a college basketball game on a TV bolted to the ceiling. A physician assistant put in 4 stitches, in and out in under 3 hours. 6 weeks later, I got a bill for $3,214. And understand, I do this for a living. I read financial statements for fun. I have opinions about depreciation schedules. And I still sat at my kitchen table staring at a line item that said, sterile supply tray, $412, like it was a language I'd never seen. There was a facility fee of $1,850. That's not the doctor. That's the charge for the building existing and me walking into it. And here's the part that broke my brain. I looked up that hospital's financials, because that's the kind of thing I do at 11 at night, and the health system that sent me that bill had posted an operating loss the year before. They lost money, while charging me $400 for a plastic tray. That's the puzzle. How does an industry that eats something like a fifth of the American economy, that bills numbers that make people physically angry, that owns the most expensive real estate in half the towns in this country, run on margins thinner than a grocery store? The average American community hospital posts an operating margin in the low single digits. Hundreds run negative. And a handful of operators in the exact same industry are printing money? Both of those things are true at once. By the end of this, you'll know where the money in a hospital comes from, where it leaks out, and the one structural thing that separates the ones that make a fortune from the ones that quietly die. It has almost nothing to do with medicine. First, one thing straight. Hospital describes about 7 different businesses that happen to have beds in them. Of the general acute care hospitals in this country, a bit more than half are private nonprofits. Around a fifth are for-profit, and the rest are government-owned. Then there are academic medical centers carrying research and teaching costs. A normal hospital doesn't. Critical access hospitals, small rural facilities capped at 25 beds, paid on a completely different formula. Specialty hospitals, and ambulatory surgery centers, which we'll come back to, because that's where the real story lives. A 300-bed nonprofit in Cleveland and a 20-bed hospital in western Nebraska share a name and a color scheme, and essentially nothing else. What I'm walking you through is the middle of that distribution. The community hospital, 200 to 400 beds, the one in your town with the parking garage and the helipad you've never seen used. Start with what it costs to have one at all. Building a hospital is one of the most capital-intensive things you can do that isn't a semiconductor fab. Construction runs somewhere around $1.5 to $2.5 million per bed once you count everything, not the room, the bed, as a unit of capacity, including its share of the operating rooms, the imaging suite, the pharmacy, the redundant power, and the HVAC that keeps an operating room at a pressure differential so air flows out of it and never into it. On a 250-bed hospital, that's $400 to $600 million before you hire a single nurse. Some recent builds have gone north of $1 billion, and you can't value engineer your way out of it. Hallway widths are regulated so a gurney can turn a corner. Air changes per hour are regulated. Generators have to carry full load for days. Then you fill it with equipment, and this is where my friend Dana comes in, because she changed how I think about this entire industry. Dana runs supply chain for a mid-sized health system in the Southeast. A few years ago, she gave me a tour that was supposed to take 20 minutes and took 2.5 hours. At one point, we're in a storage room off the cardiac cath lab, and she pulls a small cardboard box off a shelf and asks me to guess. Inside is a single drug-eluting stent. The system pays north of $1,000 for it. The price is confidential, and the hospital across town might be paying a completely different number for the identical device from the identical manufacturer. Neither of them is allowed to know. Then she walks me past the MRI suite. Machine, roughly $2 million. The room around it, another several $100,000, because you build a copper and steel shell so the magnet doesn't wipe every credit card within 30 feet. Service contract, couple $100,000 a year, forever. Then she says the thing I still think about. Everything in this building is either a profit center or a hostage, and the hard part is knowing which one you just bought. A surgical robot runs around $2 million, and the disposable instruments have use counters built in, so every procedure burns consumables. A linear accelerator is 2 to 5 million, and the depreciation on all of it hits your income statement whether or not a single patient walks through the door. Now the revenue side, because this is where it gets strange. You've heard the word charge master. It's the hospital's master price list. A price for everything: the aspirin, the tray, the hour of OR time. Almost nobody pays those prices. The charge master isn't a price list in any normal sense. It's an opening position in a negotiation that already happened. Which brings me to Marcus, hospital CFO in Ohio. 3 years ago, I asked him what percentage of billed charges his hospital actually collects, and he laughed at me. Not meanly. The way you laugh when someone asks if the DMV takes 10 minutes. Then he pulled up a spreadsheet. Gross charges, an enormous number. Net patient revenue after contractual adjustments, charity care, and bad debt, roughly a quarter of it. 25 cents on the dollar. And he told me the number that actually runs his life isn't revenue at all. It's payer mix. Payer mix is the share of your patients covered by each type of insurance, and it's the single most important variable in whether a hospital lives or dies. Commercial insurance pays the most. Work from Rand and others has put commercial payments somewhere around 2 to 2.5 times what Medicare pays for the same service at the same hospital. Medicare pays at or slightly below the cost of care. Medicaid pays below cost, sometimes way below. Uninsured mostly pays nothing and becomes bad debt or charity care. So picture 2 hospitals. Identical buildings, identical staff, identical quality, same number of patients through the door. Hospital A sits in a suburb where 60% of patients have commercial insurance. Hospital B is 8 miles away where 70% are Medicaid or uninsured. A prints money. B is on a state watch list. Same medicine, completely different business. Marcus put it to me like this: I don't compete on outcomes. I compete on zip codes. Now the twist that flips everything you assume about how hospitals get paid. You'd think a hospital wants you to stay longer. More days, more revenue. That's a hotel. It is not a hospital. Since the early 1980s, Medicare has paid on DRGs, diagnosis-related groups. You come in with pneumonia, the hospital gets a fixed payment for treating pneumonia. Not per day, not per test. One lump sum, adjusted for severity, gets you out in 3 days, and they keep the difference. Develop a complication, and stay 11 days, and the hospital eats every dollar of it. Commercial insurers copied the structure. So the entire operational incentive of an American hospital is to move you through the building as fast as is safely possible. Length of stay isn't a revenue line, it's a cost line. Every hospital in America has a whiteboard with that number on it and somebody whose job depends on it going down. Then there's labor, the biggest number on the page and the one that nearly took the industry apart. Labor runs 50 to 60% of total operating expense. That's the whole ballgame. And in 2021 and 2022, it detonated. Travel nurse agencies were billing rates that in the worst markets worked out to well over $200 an hour. I had a client, a regional system, that went from a few million a year on contract labor to north of 40 million in 18 months. Their own nurses figured out they could quit Friday, sign with an agency Monday, and come back to the same unit in the same scrubs for triple the money. The hospital paid it because the alternative was closing beds. And closing beds means turning away the commercially insured surgical patient who is the only reason your income statement works. That's when a lot of people in finance realized hospitals aren't really healthcare businesses. They're fixed cost machines with a volume problem. The building doesn't get cheaper when the census drops. The ER is staffed at 2 in the morning, whether 4 people come in or 40. Most acute care hospitals need occupancy in the 65 to 75% range just to cover their structure, and the national average has historically sat uncomfortably close to that line. Now the part that explains almost every headline about a hospital closing something. Not all care makes money, and it's not close. Orthopedics makes money, cardiac makes money, neurosurgery, spine, oncology infusion, imaging. Those carry the building. Obstetrics loses money almost everywhere outside high-volume urban centers because you staff labor and delivery around the clock for a service where a huge share of patients are on Medicaid. Inpatient psychiatry loses money. The emergency department on its own is often a loss leader that exists to feed admissions into the profitable lines. A hospital is a cross-subsidy machine. The knee replacements pay for the babies, and when the knee replacements move somewhere else, which we're about to get to, the babies stop being possible. I watched this happen in my family's town. My grandmother lived in a Kansas town of under 4,000 people, and that town had a hospital, 20-something beds. She had 2 of her kids there. When she got older and started falling, that hospital was 11 minutes away, and every one of us quietly built our decisions around that fact. It closed. First the OB unit, then the surgical service, then all of it. Last time I drove through, the building was still standing with the sign taken down, and the nearest emergency room was 52 minutes away. Something like 150 rural hospitals have closed or converted since 2010, and researchers at the Sheps Center and Chartis have flagged hundreds more as financially vulnerable. The math is brutal and simple. Low volume, no scale, terrible payer mix, zero bargaining power with insurers, a population that skews old and poor. Rural hospitals don't close because they're badly run. They close because you cannot spread a fixed cost base across 12 patients a day. So where does the money actually come from? Because some people here are doing extremely well, 3 places. First is a federal program called 340B. Certain hospitals serving a high share of low-income patients get to buy outpatient drugs at steep mandatory discounts, often 25 to 50% below normal price. But when they give that drug to a commercially insured patient, they bill the insurer the full negotiated rate and keep the spread. On a cancer infusion drug that runs tens of thousands of dollars a course, that spread is enormous. Entirely legal, written into statute, and at some systems, it's one of the largest single sources of margin in the building. It also explains a wave of hospital acquisitions of oncology practices that had nothing to do with clinical strategy. Second is the outpatient migration, and that's where my friend Ravi comes in. Ravi's an orthopedic surgeon, smart guy, terrible taste in cars. 8 years ago, he and some partners bought equity in an ambulatory surgery center. Small building, no emergency room, no overnight beds, no maternity ward, no inpatient psych, nothing that loses money. Joint replacements, arthroscopies, hand surgery, everybody goes home the same day. And because they choose their cases, they get the healthy commercially insured patient with the straightforward knee. The diabetic patient with 4 comorbidities goes to the hospital. Ravi told me over dinner, a little sheepishly, that in a good year, he makes more from owning that building than from operating on people. ASCs commonly run margins in the 20s or better. The hospital he trained at runs about 2%. Same surgeon, same procedure, completely different business. The ASC took the cream and left the hospital holding everything that doesn't pay. The third one is why we're really here. Around 2019, I was doing diligence on a health system that had done a sale-leaseback. They sold the real estate underneath their hospitals to a REIT, took a giant pile of cash, and signed long-term leases to keep operating in the buildings they used to own. On the pitch deck, it looked brilliant. Unlock trapped capital, deploy it into growth, improve return on assets. I flipped to the lease terms and felt something go cold. The rent escalators were built in. Every year, up. Regardless of what happened to reimbursement, regardless of a pandemic, regardless of whether that state cut Medicaid rates. They'd converted a flexible asset into a fixed obligation in an industry where the revenue is set by people who are not you. You know how this ends. Because it ended publicly. Steward Healthcare did exactly this at scale with Medical Properties Trust, took the cash out, and by 2024 filed one of the largest healthcare bankruptcies in American history, hospitals closing, communities losing access, the ground underneath owned by somebody else. And here's what gets me. That's the same maneuver that made McDonald's one of the great real estate companies on earth. Own the land, control the operator. It works beautifully when the operator's revenue is a hamburger you can reprice tomorrow. It works catastrophically when the operator's revenue is set by Medicare and four insurance companies and cannot be repriced at all. Which brings me to the answer. My friend Elena spends her professional life negotiating contracts between health systems and insurers. And a few years ago, she said the sentence that reorganized everything for me. I'd asked what actually determines what a hospital gets paid. Quality scores, cost structure, outcomes? She said, it's whether the insurer can build a network in this market without me. That's the business. When a system is the only place within an hour doing cardiac surgery, or when it has bought enough of the market that an insurer can't sell a plan to local employers without including it, that system sets the price. Not negotiates, sets. Research on hospital consolidation has repeatedly found higher prices in concentrated markets than competitive ones. Same procedures, no consistent improvement in outcomes. So what you're actually buying when you buy a hospital isn't a building, it isn't the MRI, it isn't even the doctors. It's a bargaining position. You're buying the ability to say no to an insurance company and have them blink. That's why the last 20 years of American healthcare have been one long consolidation wave. That's why systems buy physician practices. Not because a cardiology group is a great standalone business, but because it captures the referral and thickens the moat. The mission is real. The strategy is leverage. Honest numbers. A 250-bed community hospital. Good year, decent payer mix, strong surgical volume, occupancy around 75%. Maybe $400 million in net revenue at a 3 or 4% operating margin. Call it $14 million, which sounds like a lot until you remember the building cost $500 million and needs a 9-figure renovation inside the decade. Bad year. Occupancy falls to 58% because a competitor opened a surgery center and took your orthopedic volume. 2 big employers in town change plans, and your commercial share drops 4 points. Contract labor spikes. Now you're at -4%, a $16 million loss. And the swing between those 2 years came almost entirely from things happening outside your building. So can owning a hospital make you rich? Yes, absolutely. Just not by being good at healthcare. It makes you rich through market position, through outpatient buildings that pick their patients, through drug pricing arbitrage written into federal law, and sometimes through the dirt underneath. The medicine is real. The people working 13-hour shifts are real, and they are not the ones capturing this. The financial engine of an American hospital sits almost entirely outside the exam room. And that $400 suture tray on my bill? It was never a price. It was a number from a negotiation I wasn't invited to. If this changed how you look at the building on the hill in your town, hit subscribe, because I go this deep on a different industry every week, and drop a comment telling me which one you want next. I've got dialysis chains, veterinary roll-ups, and the funeral industry half-researched on my desk right now, and whichever one gets the most votes is the one I'm making. See you in the next one.